Namaste Vidya, Hamesha Khush Raho Vidya. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor in Department of Practice of Medicine at Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University, Jaipur. This is the series of thyroid disorders, and in today's lecture, we are going to discuss about multinodular goiter. In the last lecture, we have discussed about goiter, and today we are going to start with multinodular goiter. Multinodular goiter occurs when there are multiple nodules in the goiter. It can be broadly classified into two types: non-toxic multinodular goiter and toxic multinodular goiter. We are going to discuss them one by one. Non-toxic multinodular goiter. It occurs in up to 12% of the adults and is more common in women than in men. And the prevalence increases with the age. So, non-toxic multinodular goiter, it occurs in around 12% of the adults and more common in women than in men. And as the age increases, the prevalence increases. The pathogenesis includes multiple genetic, autoimmune, and environmental influences. The history reveals hypercellular regions to cystic areas that are filled with colloids. Fibrosis is often extensive, and the areas of hemorrhage or lymphocytic infiltration may be seen. The TSH is usually not elevated. Now, the clinical manifestations of non-toxic multinodular goiter. The patient is usually asymptomatic and euthyroid. It develops over many years and is detected on the routine physical examination when an individual notices an enlargement in the neck. If the goiter is large enough, it can lead to compressive symptoms, including difficulty in swallowing, respiratory distress, that is tracheal compression or plethora, venous congestion, but these symptoms are uncommon. There is sudden pain in multinodular goiter, and it is usually caused by the hemorrhage into the nodule. There is hoarseness reflecting laryngeal nerve involvement and also suggests malignancy. Diagnosis. Thyroid architecture is distorted and multiple nodules of varying size are appreciated. Pemberton sign that we discussed in the last lecture in goiter, it is characterized by facial suffusion when the patient arms are elevated above the head, and it suggests that the goiter has increased pressure in the thoracic inlet. The TSH level to exclude subclinical hyper or hypothyroidism with thyroid function tests are usually normal. The tracheal deviation is common. The compression is characteristically causes inspiratory stridor. The diagnosis can be done by a CT scan or MRI to elevate the anatomy of the goiter and the extent of substernal extension or tracheal narrowing. The barium swallow reveals the extent of esophageal compression. Ultrasonography to identify which nodules should be biopsied based on the sonographic features. The treatment consists of the dosage of iodine 131 radioiodine. It is used with increased frequency because it can decrease goiter size and may selectively ablate the regions of autonomy. In acute compression occurs, glucocorticoid treatment and surgery is often advised. Now we come to toxic multinodular goiter. In toxic multinodular goiter, the presence of functional autonomy is the cause. The molecular basis for autonomy remains unknown. The genetic abnormalities that are known to confer functional autonomy, such as activating TSH, are. The clinical features of toxic multinodular goiter includes subclinical hyperthyroidism or mild thyrotoxicosis. The patient is usually elderly and may present with arterial fibrillation or palpitations, tachycardia, nervousness, tremors, or weight loss. The diagnosis is done by the following test. The TSH level is low and uncombined T4 levels may be normal or minimally increased. The T3 is often elevated to a greater degree than T4. Thyroid scan shows heterogeneous uptake with multiple regions of increased and decreased uptake. Ultrasound imaging to assess the presence of discrete nodules corresponding to areas of decreased uptake. Fine needle aspiration may be indicated. The treatment of toxic multinodular goiter consists of antithyroid drugs that normalize the thyroid function. Radioiodine iodine 131 is generally the treatment of choice. Surgery provides definitive treatment for underlying thyrotoxicosis as well as goiter. Next, we come to hyperfunctioning solitary nodule. It is also known as toxic adenoma, that is autonomously functioning thyroid nodule, and it is caused by mutation that stimulates the TSHR signaling pathway. The clinical features of hyperfunctioning solitary nodule is thyrotoxicosis that is usually mild. The disorder is suggested by subnormal TSH levels, the presence of thyroid nodule, which is generally large enough to be palpable. Absence of clinical features suggestive of Graves' disease or the other causes of thyrotoxicosis. Next, we come to diagnosis and treatment. We have thyroid scan. It provides a definitive diagnostic test demonstrating focal uptake in the hyperfunctioning nodule and diminished uptake in the remainder of the gland. The treatment consists of radioiodine ablation by iodine 131, antithyroid drugs and beta blockers that can normalize thyroid function, ultrasound-guided repeated ethanol injections, and percutaneous radiofrequency thermal ablation to ablate hyperfunctioning nodules. This was all about multinodular goiter. In the next lecture, we will be discussing about thyroid crisis. This session was powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow.